Introduce our speaker for today. Professor Winston Liauw is a medical oncologist at St George Hospital, and he's going to talk about cancer shared care services.
Winston Liauw, I'm the director of the Cancer Services stream in South East in local health. I work as a medical oncologist at St George Hospital, and my main interest in that practice is in gastrointestinal cancers. The session today fits into the framework for the Chronic Diseases Working Party GP Education Program. You're familiar with this already. The specific learning goals for this webinar are to understand how the Cancer Care Centre clinicians and primary care can better collaborate on the care of our patients from diagnosis through to survivorship and palliative care, to better understand the follow-up needs of our patients, to use EviQ and Can Refer, and to be aware of the GP care project that we are undertaking in partnership with CESPH. So, first of all, I'd like to just look at cancer, and there's a lot of mythology about and first of all, I guess the thing that people do know is it's very common. A third of individuals will be diagnosed with cancer during their lifetimes. Just no internet unstable message, so if I disappear, I'll log on as soon as I can. So cancer condition of related to successful aging, and what I mean by that is the longer you live, the more likely it is that you're going to be diagnosed with cancer. And the fact that we've been successful in managing childhood and maternal illness, heart disease, and respiratory disease means people are living longer and living well. The longer you have to live, the more chance your normal tissues have accumulations that lead to cancer. The consequence of this is many of our multi, and they do have other chronic diseases. Many of our patients have some form of renal impairment, but not necessarily. They'll often have cardiac conditions like atrial fibrillation and so forth. And the cancer specialists are not actually the experts in looking after these conditions. The family doctors are, and often there are also other specialists involved with our patients. And so it's complex, and the need for shared care is really important. Cancer treatment is so we have surgery, radiation, drug therapies. It's not just chemotherapy anymore. And because of all these different modalities, cancer treatment is complex and it's difficult for patients to get. The thing I'd say though is, in the past, people have said, well, you've been diagnosed with cancer, it's all over. That's not actually the case. So we expect over 50% of people to be diagnosed with a cancer to live longer than 5 years. We expect over 85% of breast cancer patients to be cured. And for those who do not get cured by their initial therapy, we have very successful treatments now. So when I trained, we really had first-line therapies for breast, bowel, and lung cancer and prostate cancer. Now we have multiple lines of treatment for multiple types for pretty much every type of cancer, even rare conditions. And with my hematologists who treat hematological malignancy, they also have been very successful in curing lymphoma, but also conditions like myeloma now have multiple lines of therapy. So just give a very long time. And in actual fact, this is starting to create a bit of a workload crisis for us, in that people are not actually getting cured and going off and living their lives. They're being treated successfully and being well on treatment for a long period of time, but they come in regularly to the cancer centre for treatment. And so our activity has been increasing, particularly in the last 3 years. So we're now starting to see waiting times and so on. And so coordinating it is increasingly important so that we can deliver therapy in a timely way. And I see a role for primary care helping us manage this activity. So it all obviously starts with a diagnosis, and referral to cancer services is very dependent on what the suspected cancer is. Often referral is direct to a surgeon, and usually these surgeons are operating out of private rooms, whether or not the patient is public or private, and that creates a complexity around the navigation. But it's also fair to say that the majority, not all, but most of the surgeons that I work with work in the private sector, but they're VMOs in the public hospital, and they'll perform their surgery there, and they will participate in the multiple team meetings for our cancers, whether they're in the private or the public sector. So sometimes, and in my case, so the majority of my patients have seen a surgeon before they see me, and the surgeon will be referring to me. Sometimes, especially when the patient presents with metastatic disease, patient is referred directly to the cancer care centre. These referrals are sometimes directed from yourselves to individual clinicians, or sometimes there's a letter that says, my patient's had a scan and they've got spots of cancer everywhere, who should they come and see? So what will happen at the cancer centre is my registrars or the other consultants will engage with our administrative staff and triage the patients into our earliest available clinic. And what we also do is we try and work on the basis of groups. So for example, there's 4 of us that routinely treat gastrointestinal cancer in the medical oncology group. And so if somebody comes up with a not specifically referred case to an individual clinician, we'll put the patient into the clinic that is most appropriate if they've got a gastrointestinal cancer, and try and get them to the earliest possible clinic. We like to avoid patients being sent to the emergency department. That does happen. And sometimes, you know, there are clinical reasons for sending a person to the emergency department. So if somebody is jaundice, or they've out of the blue been diagnosed with brain metastases, and that's entirely appropriate. But if the patient's stable, then it's better to try and contact the cancer centre and see if the patient can be triaged and relatively urgently. There's Can Refer, which is the Cancer Institute website that provides some direction to individual cancer clinicians and multidisciplinary teams, and this provides referral information for specific ways. It's a place where our service needs to do a lot of work to uplift the information. So Can Refer, I've mentioned. Here you can go in, you can type the type of cancer in that you think the patient has or know that has. Then you can search by locality, and you all of the places or clinicians within a 10-kilometre radius, I think it is, from your centre. So if you actually type in for a patient who's in, say, Walleye Creek, it'll give you information about St George, but it will also give you information about Liauw and Prince of Wales because of the geography, but it lists the closest place first. One of the special cases is the National Colon Cancer Screening Program. These are the fecal occult blood test kits sent out to people who are Turkey, and if a positive test result is identified, then your patient may come to you seeking to have a colonoscopy organised. In some cases, as mentioned already, the referral will be directly to a surgeon, but for many people this isn't satisfactory from the perspective of cost. There is a direct access colonoscopy program that's been set up at St George, at Sutherland and at Prince of Wales. This program, the referral comes in. The concept of the direct access is that rather than having an appointment in the gastroenterology clinic, which is very challenging, the patients will be triaged, contacted by a nurse. The nurse will ask a number of questions to the patient's medical history. They'll determine whether or not the assessment by a doctor prior to having the colonoscopy procedure. So, for example, if they've got multiple medical problems where sedation might be an issue, or if they have anticoagulation and special precautions need to be taken. But if the person doesn't have any of those issues, then those be booked in for their colonoscopy, and the colonoscopy will be parked on either a gastroenterologist or a colorectal surgeon's colonoscopy list in the public hospital, and hopefully that will expedite the procedure, which historically sometimes has been slow to be undertaken through conventional pathways. There is also breast screen, and although breast screen sends out biannual invitations to screening, it's also possible to initiate a referral to breast screen, and this also enables a situation where gets better linkage back to yourselves in terms of results and so forth. So with our referral information, we will sometimes receive a referral and request results be sent in first, or request additional tests to be done. Patients may be sent registration pack, their consultation. In some circumstances, in specific tumour streams, we will be requesting very specific tests or investigations to be done, and this might be done directly with yourselves or directly with the patient or our coordinators. So once a diagnosis is made, the Cancer Institute New South Wales recommends that all of the patients be overseen by a multidisciplinary team. This does not necessarily mean that it will get discussed at a multidisciplinary team. There are clearly cases where we simply follow protocols around what the appropriate treatment is, and there are other patients which require much more comprehensive discussion in order to try and establish a treatment plan. In Southeast Sydney and at St George Hospital, we have tumour streams related multidisciplinary teams for all cancer types. We also have a couple of subspecialty teams, which, for example, we have a brain metastasis team that's separate from our general brain tumor group. We're establishing a melanoma MDT, but this will be of our affiliates at Sutherland Hospital because of the demography of melanoma. For sarcomas, we partner with Prince of Wales, but we also sometimes refer to the Lifehouse Sarcoma Unit, and the other group that's important for us is the adolescent young adult, or AYA groups. And for AYA groups, which are really older teenagers and young adults, these patients, depending on the tumor type, if they got a true pediatric tumor, they'll be managed at the Children's Hospital at Randwick. If they have a solid tumor, say they're a very young person with a breast or bowel cancer, they'll be managed by ourselves at St George, but we make additional supports from the AYA service to address some of the psychosocial needs of those patients. A treatment plan will be established prior to starting treatment, and this might be discussion at the NDT might occur before any treatment is undertaken, or sometimes it's undertaken after a definitive surgery. So it'd be very common for somebody to, say, proceed straight to bowel surgery, and then we would discuss the pathology afterwards. Of course, some of our meetings are weekly and some are fortnightly, and we need to continue people's treatment regardless of the timing of the meetings, and so out of session discussion would be very common. When the patients are being managed through the cancer centre, particularly at the initial consultations, the patients will be linked up with a care coordinator. So it might be the breast care coordinator or a coordinator allocated to gastrointestinal cancers, and they'll help navigate and coordinate the plan, and they will facilitate some of the investigations or do some of the education around the treatment. It may also be the case that the patient's linked into a clinical trial at that point, in which case there'll be sort of multiple people involved with the coordination, but we try not to duplicate too much. So finding out about treatment, when we undertake our treatments, particularly for the medical oncology and hematologists, if we're starting people on a treatment regimen, we provide information sheets from the EviQ website. EviQ is hosted by Cancer Institute New South Wales. It's a world leader in development of treatment protocols, and the treatment protocols are accompanied by patient information. And so we would print out an information sheet, a little bit like the consumer medicines information that medications come bundled with. And we provide this to the patient, and it would describe the logistics of the treatment, and it would also describe the side effects and so forth. Very often we would not necessarily consent people at the first consultation. The first consultation, we may need to do additional tests. We often need to send people away to not necessarily do staging, but to do investigations that allow us to check whether giving the treatment is appropriate in the first place or safe. And so often people will come back for a second visit to try for the consenting process. We obtain written consent from all of the patients and provide them with the printed information. We'll try and use interpreters when we can. Of course, some people bring their family members to try and interpret, but we would still prefer to use a healthcare interpreter in that circumstance. There is information on EviQ for general practitioners. Just if you go to clinical resources and click on that tab, it will bring up health professional fact sheets as an option in the sidebar, and there's information here about bowel screening, genetics, common chemo side effects, radiation side effects, immunotherapy and targeted therapies, and also screening for hepatitis, which is something that we do routinely before starting any chemotherapy regimens. So those documents are there. If I just go back again, under patients and carers, there are complementary documents to the GP documents, and there's a number of documents that have been translated into some of the more common languages in our community. So, sharing care whilst on treatment. So there's a big role in managing side effects and/or cancer symptoms for all of you, and this might be post-treatment nausea or other complications like emergent diabetes and so forth. We're happy to be contacted for advice about managing side effects or cancer symptoms. The other medical problems also need to be managed. There are a subset of patients who like to abandon you and become codependent on the cancer centre and ask us for the routine prescriptions, and they might do that when they come for their chemo treatment, or they might do it in their clinic consultations. Whilst we will provide the prescriptions, we do encourage our patients that they should be continuing to see you for that part of their care, if only because we may not necessarily be, we will be managing, example, to try and improve their diabetic control if we made it worse, but we may not necessarily be doing the routine follow-up things like HbA1cs and so forth. The other common things, of course, also need to be done, including vaccinations, and we can provide advice on vaccination for you. Generally for solid tumours, it's really not an issue around the majority of vaccines. For some of the hematology patients, there are special considerations, and some patients actually will need not just their annual influenza vaccine, but a booster because of difficulty mounting immune responses and so forth. Some patients, especially our culturally and linguistically diverse patients, the family doctor for reassurance and explanation. And look, that's entirely normal. We do spend a lot of time with our new patients, but it's always overwhelming for people. There's a lot of information to take in about treatment, but also sometimes having the trusted person that speaks your language is just really important. I should just say on that issue, we do have the opportunity now, as a good consequence of COVID, that a platform called My Virtual Care has been rolled out. We potentially have the capacity now to bring you into consultations in a virtual manner via video conference, and the real challenge there is no longer the technology, it's matching up the times for everybody, and we know that everybody has busy schedules, and it's hard to coordinate those timings perfectly, but that is an option if you would like to pursue it. So I'm not going to talk too much about cancer treatment per se today, especially about chemotherapy, but I would like to call out the new kid on the block, which is immunotherapy. It's been brewing for about a decade now, particularly in melanoma, but now many other cancers, so subtypes of gynecological cancer, renal cancer, lung cancer, melanoma. I'm starting to see some in gastrointestinal cancers, and the special type of set of cancers that have microsatellite instability, which is the mutations a bit like Lynch syndrome or the hereditary bowel cancer syndrome. Immunotherapy has proven to be very effective for some individuals and really dramatically changing their life expectancy. But it's not without side effects, and the side effects are called immune-related adverse events. These side effects are anything that ends in itis. So you can get pneumonitis, hepatitis, colitis, dermatitis of varying conditions. We have really had a run of patients in our department with myocarditis, can get nephritis, and various neurological syndromes. These are potentially very severe and potentially life-threatening. They're treated by at least temporary cessation of the therapy and high-dose corticosteroids, plus or minus other immunosuppression, depending on whether the patient's responding to steroids or whether or not the patient has got severe complications. So one of the things that needs to be important thought about out in the community and in our emergency department in patients is that the patients will often still call their treatment chemotherapy. For example, all of my chemotherapy causes diarrhea, but if the patient's on immunotherapy and they've got diarrhea, the treatment is different to treating chemotherapy-related diarrhea, and the patients might need colonoscopies to establish whether or not they've got colitis. So we very much would encourage you, if you're seeing somebody who's on immunotherapy, to just be aware that the usual cancer-related complications might be something else, and they should be referred in to the cancer centre. So cancer treatment in the community, we offer a variety of activities. There's cancer outreach program. So cancer outreach program will do home visits and potentially provide some supportive therapies, help with getting blood tests, particularly if they're time critical and not dependent on the home collection service. They might offer, in some cases, limited treatment options like chemotherapy, but we haven't really historically done a lot of that. At St. George, a little bit gets done on the Prince of Wales COP team. We also are now offering telehealth through a cancer outreach program for our bone marrow transplant patients, so they can be at home. They've got a good video camera set up. The nurses can see the patient's skin. They can see their Hickman's catheter or border cath. Patient can check their temperature, etc., and we can improve care that way. It avoids a patient coming to hospital, which is rife with infectious disease, and it's a more patient-friendly experience. Some drug companies offer specialized drugs programs for home treatment. So, for example, sandostatin injections for our neuroendocrine cancer patients. There's a couple of companies providing home monoclonal antibody therapy. This is helpful for us because it reduces some of the burden on our treatment rooms, but it also requires a fair bit of coordination as well, bring it off safely, and to also make sure that the patient's not experiencing some of those immune complications that I mentioned earlier. Chemotherapy at home programs, we're not currently engaged with a third-party chemotherapy at home provider. We are certainly exploring this, but there are some cost the issues and payment issues that make it less attractive in New South Wales than some of the other states. So after treatment, the survivorship kicks into play. Survivorship is a new emphasis in cancer services that's really arisen because we've recognized that people are doing well. They survive their cancer and they end up with complications from their cancer treatment. And there's the physical complications like lymphedema or neuropathy. They might have psychosocial issues, anxiety, or depression, or post-traumatic stress disorder. And we also identify a moment around diet and exercise and other lifestyle issues like cessation and so forth. So just a couple of months ago, Dr. Carol Harris, Catherine Clark, and Gina Hesselberg have set up a survivorship at St. George. This is initially focusing on breast cancer, but ultimately it will roll out to all the other tumor types. We're just trying to manage our resources, get our processes in place. It's a multidisciplinary team. So medical and radiation oncologists identify that we have dietitian, we have breast nurse, we have exercise physiology work. And what will happen through this group is a survivorship plan will be developed, and that will be communicated out to you. And the survivorship plan will indicate, from a cancer perspective, the patient might be doing really well, but we have identified that they need some follow-up for some therapy and exercise therapy. We'll need to engage with you to organise the referrals because of the peculiarities of the Australian healthcare system. Just can't do it directly. We hope we can provide some in-house services ourselves. There's some collaboration with a service at Calvary, which will provide gym, exercise, physiology. We've been collaborating with UTS and UNSW on survivorship research to focus on exercise in particular for managing peripheral neuropathy, fatigue, and general well-being. And there's an email link to the survivorship clinic. In terms of general follow-up after treatment, most cancers actually don't have a set protocol for follow-up. The evidence for the follow-up is quite weak in terms of improving cancer outcomes. There are some cancers like, excuse me, colon cancer, where early identification of relapse might identify resectable disease like a liver metastasis, and in which case we consider that to be still a scenario where the cancer is potentially curable. And so we do advocate for some follow-up in colon cancer, but it is controversial, and there's not been much evidence to say more frequent testing versus less frequent testing provides an advantage. Having said that, I would normally have a process in bowel cancer of quarterly visits for a year, and then 6 monthly for a year, then annual. We need to have some consensus processes, and there's some work being done on that. Unfortunately, currently there's a lot of duplication, and so it'd be very common for a patient to, in the space of a week, have a 6 monthly follow-up with their medical oncologist, their radiation oncologist, and their surgeon, and obviously 2 of these visits are probably low-value visits in terms of being duplicative. And even then, we're not entirely sure that these visits are absolutely necessary, and some of them could be done back in primary care. And we would hope that, particularly with the number of people in long-term follow-up, that we can engage primary care to be doing some shared care with these patients and reducing some of these visits. And in actual fact, one of the problems, one of the issues identified is that we have in Southeastern City, when the Bureau for Health Information does their surveys of our services, we have the highest proportion of people attending for follow-up visits in the state, and we really should be trying to manage some of those in a way that involves primary care to allow us to focus on the people who are getting active treatment. The other issue for follow-up is that it's not just about checking whether the cancers come back. It is about doing some of those survivorship things, about managing neuropathy, for example, or other complications from the original treatment. There is an alternative model, and the model is to try and have a proper shared care process where the cancer service can interact with the general practitioner and also potentially directly with the patient. Not all of our visits need to be with the cancer specialist. Survivorship issues can be identified and incorporated into a plan and managed through a third-party portal that potentially has access to your GP desktop software. There are some complicating issues with that, which I'll discuss later. Projects in progress at the moment that are being steered by Professor Mark Harris, and these include projects in cancer, started in colon cancer and expanding to breast and lung, and also Mark's got a big grant for doing this in the mental health space. Patient-reported outcome measures are coming. Patient-reported outcome measures are brief questionnaires assessing physical and mental symptoms that are administered between or ahead of appointments, usually via an app or web portal, pushing into our system or potentially pushing into your software. It allows symptom management and referral to relevant services. It potentially, if we get a list, for example, we might use the Edmondson symptom assessment. That will help streamline a consultation by identifying key symptoms that we can focus on treating. And then if there are severe symptoms, then we might refer to relevant services like social worker or allied health or psychology. From a practical perspective, the system that's being set up is being steered around the state by Cancer Institute New South Wales. It's going to push the patient-reported outcome measures into our cancer system. The patient will then have the option, if issues are identified, they'll be provided with links to appropriate information. And as I said, they may also have referrals triggered, and there'll be a dashboard on the clinician side to review these results. The benefit of PROMS is that it's been shown in randomized trials to improve, reduce the costs of care of patients. And this is primarily by reducing admissions to hospital and reducing emergency department presentations. If we can get on top of people's symptoms early, they don't get out of control and they don't land in hospital. It improves their quality of life, improves symptom management, and most interestingly, it improves survival. And so this is very much high on the agenda, not just in cancer, but also across other chronic diseases. So we're currently deploying the platforms, and I should say that some of these information may also even feedback ultimately to health pathways. GP palliative care resources are available on health pathways. I've got a slide that's out of place here. At the start of COVID, a lot of work was done with the health pathways people and our palliative care team to try and uplift the information on resources for palliative care. So you can go and find that in the health pathways space. Excuse me. And in particular, we're interested in advanced care planning. Advanced care planning has been high on our agenda for a long time, but I have to be honest that we haven't done as well as we should have. It's still an area where we are trying to embed the concept of planning for people's future at the end of life into routine practice and to be culturally acceptable. There's a fair bit of work going on at the moment in my stream to try and address those issues. But we're more than happy if in your decisions to receive copies of those and upload them to relevant places in our system. We're also in a position where if you want to ask us about what the prognosis of the patient is and so forth, then we're more than happy to contribute to that discussion. GP Can Share program. This is a program that CESPHN has funded us to undertake. It's being done in Sydney LHD and Southeast Sydney LHD, as well as St Vincent's Hospital. In Southeast Sydney, we have 4 CNCs employed across St George and Sutherland, and these complement our existing care coordinator pool. Their job is to improve interaction between primary care and cancer services and improve coordination of care for our patients. And this includes development of protocols, follow-up plans and treatment plans. We hope that it will give general practitioners more opportunity to be involved in the care of their patients with cancer. We need to improve our health pathways content. There is an education role, and we'll also be conducting some workshops for primary care as part of the GP Can Share program. And so that's really starting to kick off in progressed for a while. There are lots of delay recruitment, and it didn't help. But this is starting to gather momentum. There are lots of things we can do in terms of the interaction between the cancer centre or even at the care hospital and GPs. COVID, unfortunately, has placed a lot of demands on yourselves, and so there are competing demands, and if we show up wanting to do a research project or a new implementation, there's been some challenges for some individuals. The communication systems are really poor at the current time, and that's both at the hospital level, which really hasn't dealt with messaging adequately to date, and I'm happy to acknowledge that, admit that that's the case. I have another role in Southeast, which is as the Chief Medical Information Officer, and it's very high on our agenda to improve this, and also ultimately get e-referrals and so forth. But we've also found that when we communicate with our patients, primary care physicians, there's extraordinary communication requirements. Some people only really take phone and mail, and right through the people who have capacity for secure messaging. The time and logistics is a really difficult issue for us to navigate. We would like to be able to contact people on a regular basis, but I also completely, as a clinician myself, that you're not always available to take a phone call, and so that's something we're working through. All these remuneration systems and referral systems are rather bizarre, to be honest, and outdated. And unfortunately, MBS review has been extraordinarily slow and perhaps not productive in terms of addressing some of the bizarre practices that have emerged over the years. And indicate part of our goals with our GP Can Share program will be to improve our cancer content on health pathways to help try and navigate the system much better. This is the slide that was out of place. Palliative care. So we do offer a range of services. Palliative care sits within the cancer stream, but also looks up non-cancer related activities. We have inpatient, so acute hospital consultative service. There's a hospice at Calvary. There's outpatient and community, outpatient clinics, and we also offer the community team. The strong emphasis on early year referral for supportive care. So we don't think of palliative care as just being about the end of life or the last couple of weeks of life. Particularly, as I mentioned, our patients are living a long time, but they might be living a long time with a chronic pain syndrome related to their cancer, and we need those services in the outpatients to be available. We very much would hope that you feel confident in delivering many aspects of palliative care yourself, and more than happy to help provide education in that space. But we also recognise the need that there is a role for specialist palliative care. So I feel confident myself through my training in looking after people's pain, but I also have patients where I think I can no longer manage this adequately myself and I need to defer to somebody with more expertise. Primary care plays an important role, obviously, in the end of life care, and we're more than happy to work with you to assist particularly with pain medications. The changes in the authority prescribing for opioid analgesics has been very complicated in the last 12 months since the change to the rules. My own interpretation is that the restrictions that you see on the PBS website are extremely difficult to interpret because they're long and cumbersome. It turns out that actually you can still do a lot of stuff, but I think it's been a barrier, particularly for some clinicians to prescribing appropriately, because people in pain need pain treatment. These are contact details. Heidi and Kathy are online with us today, and they can be contacted as our integrated care coordinators, and they do cover patients across St George and Sutherland. That's the first email address for the cancer centre. Okay, and all right, so I think that's all I've got. And then there's just a reminder that there is content on Health Pathways already, but also in development. So that's all from me.
So we've got a question that says, can you describe the function of the cancer care nurses a little more? So basically within the cancer care centre, we've got cancer care coordinators who are pre-existing. So they just help navigate the patients through, I guess, the cancer care centre and the health system throughout the course of their treatment. And then we've got Heidi and myself who are newly appointed integrated care CNCs. So what we're looking at doing is better integrating the care between the cancer care centre and being that link to the GP themselves. So patients might be linked in with the cancer nurse coordinator at diagnosis. And then Heidi and I might also step in when we need to provide a bit more of a link through to the GPs. And we're looking at how we can share the care of some of the longer term follow-up patients. And we're creating care plans and linking them back in with their GPs that way.
And I think it's fair to say that we're in sort of a discovery phase at the moment, Martina, in terms of finding out what GPs want, and it's not necessarily the same from practitioner to practitioner. So there's a bit of work being done in that space, building on.
And for presenting, and also just thank you for everyone for attending.